welcome back to our channel. If this is your first time here, I'm Catherine Chong, a fertility dietitian and the founder of Pristine Fertility. And today we're diving into a must-know topic if you are trying to conceive, which is how to track ovulation and the best time to conceive. Many of you have asked, how can I track my fertile window properly? And today I have a special guest joining me, and be sure to watch the entire episode and we will be answering your question. So joining me today is Dr. Simon Nothman, a fertility and women health specialist working with Genea Fertility in Sydney CBD and Bondi. Now, Dr. Norman has a particular interest in the impact of nutrition and lifestyle change on fertility. He has a passion for empowering his patients through education. And he's here with us today to break down everything you need to know about fertility hormones and why tracking your cycle and ovulation is crucial when trying to conceive. Dr. Nothman, a big welcome to our show, and thank you so much for joining us today.
It's my absolute pleasure. Thank you for having me, Catherine. You do such a great job of bringing accessible information to the public, and I'm honored to be able to join you in that important mission.
Thank you so much, Dr. Nothman. Now, today we're going to be, chatting about one of the most commonly asked questions from our viewer about timing of ovulation, as it can get really confusing. So let's just get started by breaking it down for us in simple terms. What are fertility hormones and what is ovulation?
So before going into specific hormones, Catherine, I would like to clear up some basics because there are often misconceptions and misunderstandings around hormones. So just to start, a hormone is a chemical messenger that travels through the bloodstream to regulate different functions in the body. They can be naturally secreted from tissues in different parts of the body and can sometimes be given as part of a medical treatment. Hormones aren't good, nor are they bad, but rather they're just important parts of keeping our bodies running properly. Okay. When we talk about sex hormones or fertility hormones, we're referring to a few different hormones that control ovulation and menstrual cycle in women and sperm production in men. This process is governed by what we call the hypothalamic pituitary gonadal axis, which is a communication network between control centers in the brain and the ovaries or testes. The hypothalamus in the brain releases gonadotropin-releasing hormone, GnRH, signals to the pituitary gland. The pituitary gland then produces follicle-stimulating hormone, FSH, and luteinizing hormone, LH, which act on the ovaries or the testes. And the ovaries then respond by producing estrogen and progesterone in different amounts at different times, and that's what regulates the menstrual cycle. The same hormones are also the basis of sperm production in men, though the regulation of the axis is somewhat different and not cyclical as the same way as it is in women. So now to ovulation and the menstrual cycle. Textbooks tell us that a normal menstrual cycle length is between 21 and 35 days. But we do know that at the upper and lower ends of this range, we do not need to start thinking about whether it is actually truly normal, and we'll return to that point a little bit later. For demonstration purposes of how the cycle works, we'll use an average cycle length of 28 days. And so the ovulatory cycle consists of three essential phases. The first is follicular phase, okay? And in a 28-day cycle, that's from day 1 to 14. The cycle begins with menstruation, which actually is shedding of the uterine lining that had built up in the previous cycle. FSH, the appropriately named follicle-stimulating hormone, stimulates development of follicles, each of which contains an egg. One follicle, or occasionally more than one, is selected to be the dominant follicle, which is the one that will continue to develop and undergo ovulation, while the rest of the follicles in that cohort are actually suppressed and die off. As the dominant follicle grows, it produces estrogen, which results in thickening of the uterine lining or endometrium and helps prepare for, hopefully, a coming pregnancy. Once the dominant follicle has developed, we get to the next stage, ovulation, which occurs around day 14 in that average 28-day cycle. What happens here is that a surge in LH and FSH hormones are secreted from the pituitary, and that triggers ovulation, causing the mature egg to be released from the ovary. That egg travels down the fallopian tube, where fertilization can occur if sperm is present. And that leads us then to the third phase, the luteal phase, between days 15 and 28, again in that average length period. After ovulation, the empty follicle forms what's called the corpus luteum, which produces primarily progesterone, but also estrogen, and helps to stabilize the endometrium and support implantation. And then about 5 days after that ovulation, the fertilized egg, which by now we call a blastocyst, has hopefully traveled down the fallopian tube and is getting ready to implant in the uterine lining over the coming days. If pregnancy does occur, that pregnancy secretes a different hormone, HCG, which maintains the corpus luteum and allows for additional progesterone to be secreted. Whereas if pregnancy does not occur, the progesterone levels drop, and that's what triggers menstruation and starting of a new cycle. So the timing of ovulation is crucial, okay? And variations in ovulation timing have effects on cycle length and can also indicate underlying fertility concerns. So short cycles, those that are less than 24 days, and certainly those that are less than 21 days from beginning of the cycle to the beginning of the next cycle, they are often linked to what we call diminished ovarian reserve. That is, that a woman has fewer eggs available than we would have expected at her age. This increases the risk for premature menopause, which in itself brings with it a whole lot of complications and risks, as well as obviously the possibilities that she will have difficulty having her own children that she desires. On the other end, longer cycles, those above 35 days in length, often indicate ovulatory dysfunction, such as in polycystic ovarian syndrome, PCOS, or other situations in which ovulation is delayed or absent. Cycles that are kind of on the upper end of normal, between 32 and 35 days, are effectively normal, but nonetheless may be able to be optimized through lifestyle interventions or medical treatment, so also should not be ignored. So as I said, understanding these hormonal patterns helps in identifying potential fertility issues and optimizing conception. So a really important topic.
Yeah, thank you so much for sharing very, very detailed kind of scientific explanation, Dr. Nothman. And I can see the reason why there's so many people just felt so confused when they read our information throughout the internet. And here's actually one of our really good questions from our viewer. She asked, when I Googled it, I found that an egg takes about 30 hours to reach the fallopian tube. But I also read that once an egg is released, it only survives for about 12 to 24 hours. Does that mean that 12 to 24 hours window starts after the eggs reaches the fallopian tube, or is it right after ovulation? I'm just feeling so confused, and I'm trying for a baby boy. I just want to know what is the exact time for trying for a baby. So, Dr. Nothman, could you please help to provide some clarity around these questions?
Yeah, it's a great question. So indeed, she's correct that the egg survives for between 12 to 24 hours after ovulation, and it does take a few days to travel down the tube to the uterus. But since fertilization occurs in the tube and not in the uterus, there's not really any contradiction between the statements. The egg undergoes fertilization, like we said, in the fallopian tube, and then it takes a few more days to be transported along the tube, arriving in the uterus about 3 to 4 days after ovulation, and actually doesn't implant immediately, but continues to float around for a few more days, usually only implanting between 5 and 10 days after ovulation. So this is something that many people, including doctors, get confused about, and so thank you for the great question. She also asked about the impact of timing intercourse for sex selection, and this is a bit of a complicated topic, but would seem at the end of the day to be more talk than actual substance. Some studies previously have found that having sex close to ovulation increases the chances of having boys, while sex in the days preceding ovulation preferences girls. But other studies have found the exact opposite. So it seems that there's no clear recipe in terms of intercourse timing for sex selection. And from my perspective, probably isn't something that we should be putting a lot of effort into, because it really isn't something that we can control well. My advice, on the contrary, would be to focus on things that are able to be controlled, okay? Avoiding unhealthy habits, eating and exercising properly, good sleep hygiene, and generally trying to keep healthy.
Thank you for clarifying that, Dr. Nothman. Now, another questions from our other viewers. Here we have Mary. Mary say, I'm trying to get pregnant and it's the day after my ovulation, but I miss it. Do you think that I can still get pregnant? what's the possibility? Once again, I know that, eggs can survive about 12 to 24 hours after ovulation. So it might work, but I just don't want this month to be wasted again. And we have another question from Jasmine. So she said, I had intercourse on the fifth day of my cycle, and I ovulated on the day 15 of my cycle, and I have a 30-day cycle. Will I get pregnant? So, Dr. Southman, could you please help to provide some answers for Jasmine and Mary?
Yeah, very, very good questions. Thank you, Jasmine and Mary. So let's talk about the concepts briefly, and then we'll tackle these questions specifically.
Sure.
So tracking ovulation is one of the best ways to pinpoint your fertile window. And the fertile window is the days in which conception is most likely. Okay. To understand what the fertile window actually is, we need to recognize that sperm can actually survive for quite a few days in the female genital tract, something in the realm of 4 to 5 days. And that gives us a fertile window of about 4 to 5 days before ovulation and another 12 or maybe 24 hours after ovulation. So that gives us a fertile window of 5 or 6 days. So while there are a few days in which pregnancy can be achieved, nonetheless, the single best day to have intercourse, if you could only have once to achieve pregnancy, is the day of ovulation or marginally before. Okay. So how do we track ovulation? Apps can give estimates based on previous cycle patterns, but they don't actually measure real-time hormonal changes, which obviously is more accurate, especially for women whose cycles aren't really regular. And that's where formal ovulation tracking comes in, is much more reliable. So let's talk about a few different methods of ovulation tracking. One that I'm sure your listeners and viewers know about is ovulation predictor kits, okay? Those sticks that you can buy at the pharmacy and that you pee on and it gives you an answer. And what these do is that they detect the LH surge in urine, okay? And that can be picked up between 24 and 36 hours before ovulation. Now, this indicates the single best day to have intercourse, but it misses the preceding days that make up most of the fertile window. Okay, so it can be a very useful tool, but also keeping in mind that it misses a lot of very useful days to be having intercourse. Another technique that some people may have heard of is testing basal body temperature, and that involves using a very sensitive thermometer to check the temperature every morning. And what we're checking for there is a slight rise in temperature that occurs after ovulation has occurred. Now, this again assesses for ovulation that has just happened. Okay, it can't be used to predict ovulation in advance. And so for the most part, only tells us once the fertile window is finished. Okay, so it's not very useful for actually predicting when is the best time for intercourse. Another one is looking at cervical mucus changes. Okay, cervical mucus changes through the course of the month under the influence of estrogen and then progesterone. And as we're approaching ovulation, mucus becomes clear, slippery, and stretchy, which essentially makes it easier for sperm to be able to get through the cervical mucus and hopefully reach the egg. This can be quite a good technique for women to use, but it does require practice to be able to use it well as requiring the woman to actually vaginally examine herself, which is something that some women do feel a bit uncomfortable about, while others are very comfortable doing. So it is something that won't be appropriate for everybody. We're heading now into the kind of more technical, formal approaches, okay? Yep. The next of which is based on ultrasound, using ultrasound monitoring, which is what essentially is used in fertility clinics, and that allows us to track follicle growth and assess ovulation timing that way. It also gives us an assessment of the uterine lining development, which obviously is important when it comes to implantation. And usually it's something that wouldn't be done standalone, but would be used in conjunction with blood tests, which is the last method that we're going to discuss. So serial blood tests over the course of a cycle can help to identify the hormonal changes that occur with the growth of that dominant follicle that we discussed earlier and prior to ovulation. And that way we're able to both recognize the upcoming fertile window and also the time of ovulation itself. We can then do another test about a week later that we refer to as the mid-luteal phase progesterone, and that helps to confirm whether ovulation has occurred. So often combining multiple methods gives a clearer picture, like we mentioned with ultrasound and blood tests, or using the Predictor kits together with mucus tracking, and that can give a much clearer picture, especially for women with irregular cycles or having difficulty conceiving. It's important to recognize that on a technical level, all of these tests essentially are looking at changes associated with ovulation, and none of them can actually prove that ovulation occurred, that an egg has left the ovary. Even on ultrasound, we can't actually see an egg. And all of the other tests are looking at markers, essentially biochemical markers of the hormonal changes that happen before and after ovulation. But again, none of them can actually prove that ovulation occurred. As one of my medical school professors quipped some 20 years ago, the only test that can truly confirm that ovulation has occurred is a positive pregnancy test. But obviously, ovulation is only one of the many factors that is required to achieve successful pregnancy. Anyway, your viewers' great questions. Yeah. Marie asked if the month is a waste of time if she missed the day of ovulation itself and can only have intercourse the following day. So as we discussed, we expect that the egg will no longer be viable above about 24 hours after fertilization, and thus it wouldn't ordinarily be able to be fertilized at that point. So if that's the first opportunity she's had to have sex with her partner that month, it's very unlikely she'll get pregnant. However, as we mentioned, we have a 5 or 6 day fertile window. So even if she's missed the ovulation day, which may be the single best day, if they've managed to have sex a couple of times in that fertile window, they nonetheless have a good chance of being able to conceive. Okay, so it's important to recognize that it's not just a matter of the day of ovulation itself, okay, but of making the most of that whole fertile window. And Jasmine essentially was asking the opposite question about what happens if she has sex on day 5 of a 30-day cycle, so about 10 days before she ovulates. Similarly here, it would seem that the chance of achieving pregnancy is quite low. So if she is trying to get pregnant, it would be worth thinking about or discussing with a professional how she could time her ovulation and time intercourse better to maximize her chances of conceiving. I would like to just mark this all with a big star or asterisk. Note that the old studies that looked at natural fertility in women with regular cycles found that there was a chance of achieving pregnancy on every day of the month. Yeah, much more around ovulation. Nonetheless, from the beginning of the period through to just before the next expected period, there was some chance of achieving pregnancy. And from my perspective, I think we can learn a couple of things from that. Okay. One, that we need to recognize that we don't actually understand everything when it comes to egg and sperm function. I mean, we also doctors. And occasionally that fertilizations that shouldn't occur. And 2, also that women don't necessarily know their ovulation timing, even when cycles are regular, that there can be some fluctuation in the timing of ovulation. So basically the bottom line is that we need to maintain a bit of modesty and recognize that, well, Mother Nature still has a lot to teach us all, and we can only do the best we can.
That's right. I love that you ended that questions with we can only do our best, and Dr. Nothman. I'm sure that all these women are feeling quite a lot of pressure when they're desperately, trying for their baby. That actually also bring me to the next question I have for you, Dr. Nothman. For some women, like you highlighted, ovulation doesn't often occur as smoothly. I suppose what are some of the early warning signs that a woman may have ovulatory issues, and at what point women should think about, all right, I need to see a doctor maybe for further discussion and further testing?
Yeah, really, really important. And it highlights the importance of women listening to their bodies and really being in tune to what's going on. So certain cycle patterns can indicate ovulation problems and sometimes also suggest significant issues that deserve attention. So irregular periods, even within the normal range, obviously makes it very difficult to predict when ovulation is expected and makes timing intercourse really challenging and frustrating. And that is the type of situation in which formal ovulation tracking or perhaps a bit of medical treatment can be really helpful, and speaking to a doctor in that situation can be really important. Having very light or very heavy periods likewise could indicate an issue with the way that the uterine lining is developing and may have implications for that desired pregnancy as well. Lack of ovulation symptoms, okay, such as no changes in cervical mucus, an absence of mid-cycle pain. That can also be an issue, may indicate that ovulation isn't happening and is worthy of discussion. And as we mentioned before, periods that are shorter or longer than the normal range, with frequent cycles suggesting that there could be a diminished ovarian reserve with risk for premature menopause, and longer cycles suggesting polycystic ovarian syndrome or other hormonal abnormalities, and could also be a sign for perimenopause. Now, these are all quite different and quite complicated, and I wouldn't recommend that anybody try to self-diagnose what their problem is, but certainly these are all situations that should be taken as a sign to see a specialist. And I guess that's a good segue to your second question of when should couples see a doctor? So as a general rule, we know in fertility that age is a really important factor, and it forms a central guide to when medical attention should be sought. So if the female partner is under 35, you should see a doctor if you've been trying for 12 months without success. If the female partner is over the age of 35, we generally shorten that to 6 months, again, because we know that there are increased risks beyond the age of 35. These are rules of thumb, and they're based on the statistical chance of a fertile couple achieving pregnancy given enough time, and essentially assume that there's no reason to think that there might be a problem. However, if there is a condition, which is known or suspected to affect fertility, then there's no need to wait at all. And on the contrary, you should be seeking specialist medical attention immediately. Such situations that would justify seeking attention immediately include, but aren't limited to, irregular, very long or very short cycles, a known or suspected condition that can affect fertility, such as PCOS, thyroid disorders, previous chemotherapy, symptoms of early menopause, symptoms of endometriosis, such as significant period pain, painful intercourse. And likewise in men, low libido, a history of testicular trauma or operations, use of anabolic steroids or anti-balding medications. So while there are general age-based guidelines for how long you might want to wait before seeking help, if there is any known or suspected fertility issue, you don't need to wait at all before seeking care, and getting assessed early can save valuable and really important time later.
Thank you for clarifying that. Now, Dr. Nothman, I'm going to shift the gear a little bit. We're going to be chatting about progesterone hormones.
Okay.
So one of the concerns that I guess frequently come out in my nutrition practice is women's often highlight to me that they are a little concerned about the low progesterone level, or I know from my understanding in clinical term, it refers to luteal phase defects. I have read about this condition can potentially also impact on especially implantations and early kind of pregnancy phase. So I know that there's still a lot of debate around this condition, Dr. Nothman. Like, can you help me to kind of shed some lights in terms of what's the latest evidence and understanding we know so far? Should women be worried about low progesterone?
Fantastic. Thank you, Catherine. So progesterone is an essential hormone for supporting implantation and in early pregnancy. And essentially its name literally means for pregnancy in Greek. Going back to what we discussed about the natural cyclical function, we remember that the luteal phase, starting from ovulation and going through to the next menstruation, if no pregnancy is established, is fairly constant length, about 14 days. And it's during this time that progesterone is secreted, and with the aim of support for the upcoming pregnancy. Luteal phase defect essentially is when the luteal phase is too short and may lead to insufficient progesterone levels for early pregnancy support. That said, as you kind of alluded to, it is a matter of ongoing professional debate whether luteal phase defect is actually a thing or whether a significant defect is actually quite rare. And for the most part, when ovulation timing is tracked accurately, studies seem to suggest that it's not actually much of an issue as once it was thought. But at the end of the day, whether it's rare or common, whether it's minor or significant, there are some things that we can do to help support progesterone levels. Okay. So on the side of women themselves with professional guidance, number one, diet. So progesterone is a hormone that requires a complex combination of enzyme functions to be able to build it from basic ingredients such as fatty acid chains. And that requires a generally good, nutrient-rich diet full of vitamins, minerals, and healthy fats. Foods rich in zinc, vitamin B6, magnesium, such as seeds, nuts, spinach, leafy greens, whole grains, may support progesterone production. And regardless of whether they specifically support progesterone production or not, they are part of a healthy diet and will help support your fertility journey in general. So it definitely should be part of how we're eating. Likewise, stress management. We know that chronic stress can disrupt the function of the hypothalamic pituitary ovarian axis and can potentially impact on progesterone levels. Techniques like yoga, meditation, acupuncture, etc., may also have a role helping to regulate hormonal function. So diet, stress management, and lifestyle factors in general are potentially aspects that are within each woman's control to be able to optimize their fertility fitness. Beyond that, there's also potential for medical intervention to provide additional luteal phase support if we really think that progesterone levels are inadequate. So if progesterone levels are consistently low and periods come somewhat earlier than expected, progesterone supplements may be considered. These usually take the form of vaginal pessaries or gels and can create a kind of unpleasant discharge, but other than that, are generally quite a low-risk treatment. This sort of treatment is usually undertaken in the context of fertility treatments, but it can also be done in the context of natural conception if it's thought to be justified. Again, obviously, this isn't something that women should be self-diagnosing or selecting this sort of treatment themselves, but rather that should be discussed with a specialist.
Yeah, 100%. Always just a reminder to everyone here, before you're trying something new, be sure to consult your healthcare professionals, your medical provider before you start something new. Now, Dr. Nothman, I can tell, and I know you're very passionate about nutrition and lifestyle intervention as well, same do I. So I guess that my kind of next question before we wrap up as well is, can you share how do lifestyle factors like nutrition, environmental toxin exposure, stress, sleep impact on fertility hormone and women's ability to conceive, Dr. Nothman?
Yeah, absolutely. So like you said, it is one of my areas of interest, the connection between lifestyle and fertility medicine, and you two are very passionate about. It shouldn't come as a surprise to anybody that the things that we put in our bodies can have an impact on our fertility. Of course, it's always important, as we've mentioned, to seek personalized advice, but just in terms of general guidelines that can serve as a good starting point, from a nutritional perspective, generally speaking, a Mediterranean-style diet rich in antioxidants, omega-3 fats, and other healthy fats can support hormonal balance and egg quality. This means lots of vegetables, fish, other lean proteins, olive oil, and probably more important than all of that, reducing processed foods. This is something that's really important and would always be number one on my list of advice for couples trying to achieve pregnancy. Stress and sleep are big issues in the modern world. We live in a very stressful environment, social media, and none of us, I think, get as much sleep as we should, and certainly not as good quality as we should. And these are, again, things that everyone can give a little bit of attention to. We know that stress and poor or disordered sleep can negatively impact normal hormonal function, including reproductive hormones, and that managing stress through mindfulness, relaxation, gentle movement, and adequate sleep can help support proper hormonal function. Something that you referred to and that has got a lot of attention on social networks recently is endocrine disruptors and other toxin exposures. And that essentially refers to different chemicals that are found in the environment that may potentially interfere with normal hormonal function. Plastics, pesticides, and also personal care products such as deodorants and makeup can potentially interfere with hormone function. So reducing exposure can be beneficial. The problem is that such chemicals are all around us, so it's really hard to know where to start and where to stop. But some things may assist with reducing toxin exposures before and during pregnancy, such as preferring glass or metal containers over plastic, avoiding BPA, and making sure you get plenty of good quality nutrition loaded with lots of vitamins and minerals, and reducing those highly processed foods once again. If the budget permits choosing organic produce, then that might be the icing on the cake, but probably only has a relatively minor contribution compared to reducing highly processed foods and just generally getting a high vitamin, high mineral, nutrition-dense diet. And obviously this should be obvious, I would think, to your audience, but nonetheless, avoiding cigarette and vaping exposure, alcohol and other drugs is clearly important when it comes to optimizing reproductive health. and reducing risks during pregnancy and to offspring. Catherine, if you don't mind, I'd like to jump on my soapbox for a moment and talk a little bit about male fertility and lifestyle change. A bit of a bugbear for me is that fertility is often seen as just a women's issue, but we know that actually male factors contribute to about half of infertility factors. That is to say, half of the couples having difficulty building the family they want, there is some degree of male factor infertility, and in a third, it is actually the primary factor. So just as lifestyle changes can improve female fertility, they're equally crucial for men in optimizing sperm health. Understanding that lifestyle changes are important for both men and women leads us to a central aspect of my approach to couples struggling with fertility, making the necessary lifestyle changes together as a couple. And that not only improves conception chances, but also helps reduce feelings of blame, guilt, and shame, which many couples feel when struggling to conceive. So make sure that you're in this journey together, including optimizing your lifestyles and preconception health together. I think it's absolutely critical.
Yeah, thank you to kind of wrap up so beautifully, Dr. Nothman. I can certainly feel that whenever I talk to a lot of women, I guess that there's always part of them, the guilt, the shame, the blame. They feel like it's their fault when they're struggling to get pregnant. So any kind of final message, Dr. Nothman, especially, like you say, for women who have been trying to conceive for many years, but nothing happened yet. They just feel so discouraged at this moment. What are the key messages you would like to share with them?
So we know that fertility struggles are really emotionally draining, but you're not alone. You certainly don't need to feel guilt or shame. If you've been trying for a while, it can be really important to seek specialist support, and they can help provide clarity and options that are tailored to your situation. As we've mentioned, no two people are the same, and there are general rules, but really it needs to be tailored to you. I think at the end of it, when it comes to it, you need to be kind to yourself. And again, not just women, but also men and the couples between themselves. The process can be really hard and occasionally really, really long. So everything that you do to improve your health is an important step in the right direction. So making those small changes, whether in lifestyle, medical support, or stress management, can make a real difference. And at the end of the day, be kind to yourself, because this can be quite a challenge.
Thank you, Dr. Nothman. This really has been an incredible, really insightful conversation with you. Really thank you. And, from our team as well, it's the time that you spend with us and with our audience, clarifying so many, options and really giving not just a hope, but really evidence-based step for women and couples to really learn and knowing that there's always an option for them. Now, Dr. Nothman, before we go, can you tell our audience, our viewers, where can they, connect further with you?
Absolutely. Thank you, Catherine. Yeah, like you said in your intro, I'm all about empowering individuals and couples through education. So really, it's an honor to be with you to help inform your viewers.
Thank you.
For anyone interested in more, my Instagram also has a constant stream of fertility-related content. And for anyone who wants to discuss their personal situation with me, the best way to go about it as a first step is to visit my website, drsimonnothman.com.au. That's Dr. SIMONNOTHMAN.com.au. Like you mentioned, I consult from the Sydney CBD and Bondi Junction, as well as offering telemedicine consults, so including all around the country. Yeah, I'd be greatly honored to be able to help your viewers with their struggles if they have any questions.
Thanks again for being here, Dr. Nothman, and I'll surely attach all your details in our description box below. Thank you so much, and if you found this episode helpful, be sure to like this video, subscribe to our channel, and even drop any questions that you have in the comment box below. Or even better, share this video with someone you know who are in this journey, who are still trying to find an answer to try to have that beautiful baby. So thank you so much for watching, and we will see you in the next episode. Bye for now.